Hello. Good morning, everyone. In the last class, we saw how to examine visual acuity of the patient. And usually, when we do ophthalmology examination, how we proceed is we go from the outside to the inside. So we start examining actually from the orbit, but I'm going to start with the lid today. So we start with the orbit, the lid, then we uh, examine the ocular coats, okay, and then further that's how we proceed. So from anterior to posterior, that's how we proceed with the examination. So today we're going to deal with examination of the lid. Okay. Just before we start with examination, I'll tell you briefly about the anatomy. Eyelids are actually protective structures for the ocular, the eyeball. So what happens is there's this upper eyelid, which is from the eyebrow to the upper eyelid margin. Um, okay. And there's this lower eyelid, which is from the lower eyelid margin up, and it merges with the cheeks. Okay. So there are these lid creases. These are very, very important. Okay. There's this upper eyelid crease, which divides the upper eyelid into the orbital portion and the tarsal portion. Okay. And there is a lower eyelid crease also. Okay. What are the layers of the eyelid? You need to know this because each of this has important functions in the, lid functions. All of them are responsible, like all the structures are responsible for various functions in the lid, right? So we have this skin. Now the skin is the thinnest on the face. Like, okay, it's the skin on the eyelid is very, very thin. Then you have the subcutaneous areolar tissue. It does not contain any fat, and it's a accumulation of loose areolar tissue. What happens is when there is any edema, it fills in around in the periorbital region. Because it's very, very loose, there is a lot of accumulation of fluid, and there can edema can occur very easily in the eyelids. Then the next layer is the striated muscle fiber layer, which comprises of your orbicularis oculi, which is responsible for closing the eyelid, and the levator palpebrae superioris, which helps in elevating the eyelid or opening of the eyelids. Further, then there is submuscular areolar tissue. Okay, and then there's fibrous tissue. Now, this fibrous tissue, it helps, it's basically the skeleton of the eyeball, okay, and it gives the structural integrity to the eyeball. This fibrous tissue it comprises of the orbital septum, the tarsus, and the medial and lateral canthal ligaments. Further, you have non-striated muscle fibers, which comprise of Muller's muscle, which are innervated sympathetically, okay, and then there is tarsal conjunctiva. Now, what are the functions of the eyelid? There is a protective function. It protects the globe. Then the movement of the eyelid, basically the blinking action of the lids, what it does it evenly spreads the tear film. Okay, that is very, very important. If it doesn't, the tear film is not evenly spread, it's going to cause dry eye, which is very, very troublesome to the patient. So the blinking action, what it does Hello. Okay, I think there was some technical error. I'll start with examination again. So the first and foremost thing that we see while we're examining the eyelid is the lid position. So normally what happens is that the upper lid, it covers to 2 mm, the superior 2 mm of the cornea. That's the normal position of the upper eyelid. Whereas the lower eyelid, it will just be an approximation with the limbus. Okay, so this is very important because this can tell you about a lot of disorders that can happen if the position is not in place, which we're going to discuss in the next few slides. So you have to remember that the upper lid, it covers the 2 mm of the cornea, the superior 2 mm of the cornea, and the lower lid, it just touches the limbus, right? Just as shown in this diagram. So while we're examining the eyelid, you have to look at all these structures that you can see in this particular image. So you see the lid margins first, okay? Then you see the all these folds. You see the upper lid crease. Usually it's about 6 to 8 mm in females and about 4 to 6 mm in males from the lid margin. You have to see that the lid margins meet at the canthi. You should see the orientation of the canthi also, whether medial canthus is lower or lateral canthus is lower, because that tells you, there's this thing called mongoloid slant and anti-mongoloid slant. So in mongoloid slant, what happens is that the medial canthus is lower than the lateral canthus, whereas in the anti-mongoloid slant, you'll see the reverse of this. Okay, so you have to appreciate the lid crease because that's very, very important. Now, lid crease is actually formed by, as I told you, that there are these muscles called the levator palpebrae superioris. They give fibrous slips into the skin, and that forms the upper lid crease. Now, that's important because it holds a lot of relevance, one, cosmetically for the patient, two, for our surgical aspect on ptosis. Then there is these lower lid crease, and there are these various folds when the lid, I mean, the eyelid merges onto the cheek and everything. There are the folds, these are created, the nasojugal groove and everything. Okay. Then coming on to lid position, as I already said, that it has to cover the top, upper lid has to cover 2 mm of cornea, and lower lid has to just approximate the limbus. Now, what happens is when the upper eyelid droops, okay, if you can see in this image, the first one over here, when the upper eye is, uh, covering more of cornea than the 2 mm that's normal, that is called ptosis. Okay, and if the upper lid is higher than that, okay, if you can see the scleral show over here. Can you see the white portion? That's the sclera. If the lid is higher than its normal position, you'll be able to see the sclera on top, right? So that is called lid retraction. Okay, this is lid retraction is very common in thyroid ophthalmopathy. Okay, ptosis can be anywhere from congenital to acquired. There are a lot of reasons for acquired ptosis. It can be congenital also. I'll tell you briefly about ptosis in the next slides. Then in the lower lid, there's something called inverse ptosis. Now what happens is, usually I said normally it covers only up till, I mean, it just approximates the limbus. But if it's going further from the limbus, that it's covering more of cornea, then it's called inverse ptosis. Whereas if you can see sclera below, like in the lower portion, then that is called inferior or lower lid retraction. Okay, then coming to congenital ptosis. Uh, these are just basically just for your clinical review. Okay, so congenital ptosis is actually because of a dystrophy of the levator palpebrae superioris. Okay, so that muscle is not formed well. So what happens when it's not formed well is it does not contract properly, and it does not even relax properly. So some particular features about congenital ptosis are that there's an absent lid crease. As I already told you, that LPS is the one that gives fibrous slips to the skin, which lead to formation of lid crease. Now there's a dystrophy of LPS. So it also leads to absent lid crease. Now, what is lid lag? That you can test when you ask the patient to look down. Okay, from primary gaze, you'll see that the normally what should happen is that the lid should follow the eyeball. So like in the image below, yeah, in this image you can see that from the normal position that would have probably been here when the patient is looking down, the lid follows the eyeball. But on the other hand, in his left eye, what you can see is that the lid is not following the globe. And it's lagging behind the globe when he's looking down. So this is called a lid lag. So it's very characteristic of a congenital ptosis. Then you have to look for levator function. Okay. Usually in congenital ptosis, the levator function usually it will be poor because it's a dystrophic muscle, and even the lid lag for that matter happens because the muscle is dystrophic. So what happens is it does not even relax properly. The relaxation of LPS is required for the normal function of the lid, that it should be able to follow the globe. That's normal, and that will be happening only when there is relaxation of the LPS. Okay, and congenital ptosis may be associated with uh, Marcus gun jaw winking phenomenon. In this, what happens is that when the patient is asked to open his jaw and move his jaw to the opposite side of the ptosis, the ptotic eyelid will go higher, as in there will be retraction in that eyelid. Okay. Then some particular things about acquired ptosis is that lid crease in some may be normal, or in cases where there is aponeurotic ptosis because of dehiscence of the LPS, this might actually go upwards. Okay, so there will be a higher lid crease and aponeurotic ptosis. There will not be any lid lag, and the levator function, it can be variable. In some patients it will be good, in some patients it will be poor. Now, how do you check for LPS action, and what is LPS actually? So, levator palpebrae superioris is a muscle, right? It's a striated muscle. It originates from near the orbital apex. You have to read your theories to be able to understand on this. So, and it originates near the orbital apex, at the orbital apex near the tendinous ring, and it comes forward and spreads in a fan-like fashion and gets attached to the superior tarsal plate. Okay, so how do you check for levator palpebrae superioris action? This is very, very important for ptosis, because what it tells you is first, what is the strength of LPS, and accordingly you have to decide what kind of surgery you want to do, right? So how do you check for LPS action? You will ask the patient to look down, okay, and then you mark the upper lid, okay, in down gaze on a scale. You keep a scale next to it and align it with either 1 centimeter or 0, however you're comfortable. And then you will ask the patient to look up. Yeah. So in the first image, you can see that the patient is looking down. Okay. And then you have aligned that with the readings on the scale. Okay. Once the patient has looked down, then you're supposed to block the frontalis, because even frontalis causes elevation of the lid. So you're supposed to block it so that you can properly measure the LPS action. How do you block it? You'll just put your thumb on the just above the eyebrow of the patient and block the action of frontalis. Okay, this has to happen when the patient is looking down. All right. So once you have blocked the action of frontalis, now you will ask the patient to look as far up as he can. So now you can see in the second image that the patient is looking up, but there is very minimal elevation in the ptotic eyelid, approximate. So this was here, it's like 1, and then over here it becomes 1.5 centimeters. So it's only a 5 mm LPS action. So that is how you measure LPS action, right? So how is LPS action? What excursion is considered normal? It's normal when it's 15 mm or more. It's good when it's 8 to 14 mm. It is fair when it's 4 to 7 mm, and it's called poor when it is lesser than 4 mm. So in cases of poor LPS action, when you know how much ever you change the LPS, whether you advance it or you resect it, it's not going to make any difference, because anyway the action is very, very poor. So in cases of poor LPS action, you usually go for frontalis sling surgeries. Okay, and if you have a good LPS action or a normal LPS action, resection can make a lot of difference. Now, in cases of ptosis, you have to, other than your lid position that we saw, then the LPS action that we saw, okay, then you also have to look for lag of thalamus. Now, what is lag of thalamus? It is basically the inability to close the eyelid. Okay, so some part of the, you can see the eyeball even when the lid is closed. For example, in this image over here, you can see that you can see the sclera. Okay, the eyeballs have gone up, but the sclera is visible. Okay. So this is actually, I mean, the closure of the lid is a function of orbicularis oculi. You see this muscle here going around the eye. That is the orbicularis oculi. Now, in case lag of thalamus is present, how is it significant for us? Because if we do ptosis surgery in a patient who has lag of thalamus, already there is scleral exposure here. Now, normally what happens is that the eyeballs, when the person tries to close, they will go up. Okay. So what happens is that in case of now, if the patient is unable to close the eyeball, and if they may have a lot of exposure if there is lag of thalamus. Okay. Then you are also supposed to check for Bell's phenomenon. Right now, what is Bell's phenomenon is when you have to check for Bell's phenomenon by holding the upper lids, okay, and asking the patient to basically you have to hold up the upper lids and you have to ask the patient to forcefully close the eyeball. So then you see the movement of the eyeballs. Usually they'll go up, okay, and what happens in a poor Wells phenomenon is that they will not go up and they will stay in the same position as in the primary gaze. And that is a contraindication for ptosis surgery because if you do ptosis surgery in those patients, it's going to lead to a lot of exposure, and that's not what you want for the patient. Eventually, it will lead to exposure keratitis, and that's not something we want for a patient, right? So, as I said, closure of the lid is a function of orbicularis oculi, and the orbital part of it causes forced closure of the lid, and the palpebral part of it causes gentle closure of the lid. Yeah. So then when we inspect, we are supposed to look for the color of the skin, the fullness of the lid, the laxity of the skin, and any eruptions or mass that we can see. So now what happens is when you see the color of the skin, the color may be normal, okay, according to the race of the patient and everything. It can be hyperpigmented, which can be a generalized hyperpigmentation like you see in this, which are dark circles. Okay, you use kojic acid creams for it. Then it can also be a hyperpigmentation if the patient has a chronic spring catarrh, right? So they'll keep rubbing the eye and that eventually leads to hyperpigmentation, right? So you can see over here that it's pigmented around. Then it can be a localized hyperpigmentation like this, which is actually a nevi. Okay, this variant wherein the nevi of the upper lid and the lower lid come in approximation, it's called a kissing nevi. And there can be all other localized hyperpigmentations also like moles on the eyelid. Then there can be hyperpigmented lids, which can happen in a vitiligo, which is an autoimmune condition. Then it can happen in xanthelasma like this, where it usually happens in patients who have hypercholesterolemia. Then it can happen in albins also, right? You can see that this is uh, a hyperpigmented eyelid. Even the whole face is actually it lacks pigment, even though eyelashes for that matter lack pigment. You can also see the iris over here, it completely lacks pigment. So what this red glow that you can see comes from the fundus. Okay, and they completely lack pigment and they cannot block any light. And these patients are very, very photophobic. And the other kind of discoloration that you can see on the skin is ecchymosis because of a trauma. Okay, so if there's any trauma and there is bleeding of the superficial, I mean hemorrhage of the superficial vessels, that will lead to pinkish or blue, I mean pinkish blue and reddish blue discoloration of the eyelid skin. That is ecchymosis. Then fullness, coming to fullness, it, as I already told you that the eyelids are very, very, the skin is very thin, the subareolar tissues, I mean, it's very loose. So the edema is very quick in eyelids for it to happen. It happens really rapidly. So it can be diffuse, which it can be either in one eye or both, that is unilateral or bilateral. And it can be diffuse in cases of allergies or insect bites, nephrotic syndrome, myxedema, cellulitis, or any other infections. It can happen in post-surgical cases or cases of endophthalmitis, panophthalmitis, and all that. And it can also be localized. Now you have to look for the localized ones. For example, over here, this is a chalazion of the upper eyelid. Now, how does a chalazion form? Does anyone know? Can anyone tell me what is a chalazion? Yeah. So, okay. It is a block of the ductive gland, as rightly said by Sumit, but what gland are we talking about when we talk about chalazion? Ye- Yes. Yeah. Correct. So it's actually because of it's a it's basically not an infection, okay, and it's not even inflammatory. So this is a swelling of basically the glands. It involves the meibomian gland, correctly. Yeah, chronic lipogranulomatous inflammation, very rightly said. Okay. Then there can also be. So what do you do about a chalazion? If you see a patient of chalazion in your clinic, you've diagnosed them with chalazion. Now what do you do about it? Correct. So yeah, if the patient has a lot of trouble with it, you have to take them for incision and curettage. You can actually initially begin with hot compresses, yes, and go for maybe a short course of antibiotics before you take them. Also, you should always ask them for any history of uh, raised blood sugars or any of that, or it's also caused by refractive error, right? So you should get all this evaluated in a patient of chalazion. Yeah, triamcinolone is also injected. If it's near the lid margin and you cannot do incision and curettage in them. Yes, it does get infected sometimes, and that is when you call it a hordeolum internum. Okay. So then the next thing, there can be cysts on the eyes, okay, which can be localized. You have to look for them. Various reasons, I mean, various causes of cysts are present on the eyelid. You should look for all these. Now, what is a sty? Can anyone tell me what is a sty? Okay, what glands does it involve? Or does it involve glands at all? Correct. So basically, it's the inflammation of Zeiss and Moll's gland. Okay. So this will present. How is it different from a chalazion? First of all, it's an infective thing. It's an inflammatory lesion. Second of all, going to usually be present on the close to the lid margin, right? So it will be closer to the lashes because that's where the glands also open, right? So and chalazions they usually are away from the lid margin. Correct. So then other localized lesions that we see are warts or verrucae. Okay, so you should be looking for all this when you're examining the eyelid on inspection, right? So then what is skin laxicity? You should look for that also because a lot of patients will have loose skin of the upper lid or like loose skin on the lower lid. And that can either be one as a senile factor, okay, because it leads to, I mean, tissue degeneration and all that, and that will lead to redundant skin. Okay, and that's called dermatochalasis. So when it's because of this, basically it's when it's redundant skin, that is dermatochalasis. But sometimes the skin becomes redundant because of recurrent episodes of lid edema. So there's lid edema, then there is resolution, then again there's edema, then there's resolution. In those cases, when the redundancy is because of recurrent edema, then that is called as blepharochalasis. Okay, so on top you can see that there's this image that is a senile patient. So when the upper eyelid is becoming redundant, that is dermatochalasis. In the lower one, you can see that it's a relatively young patient, and you can see how you'll be able to make out that this, patient has probably suffered from previous, or the patient will give you a history of recurrent edema or something like that, and then you'll be able to tell that, okay, fine, this is blepharochalasis. Then you should look for any sorts of eruptions in the eyelid because a lot of times these viral infections, herpes simplex and herpes zoster, they present with vesicular eruptions on the lid and forehead, and they always respect a midline. So if you see in the second picture below over here, you see that the infection is only onto the right side of the patient and it has not gone onto the left. Okay. And does anyone know what is Hutchinson sign? Yeah. Correct, correct, correct. So yeah, if the nose is involved, that it's going to tell you that most likely the eye will also get involved. And why does that happen? Yes, correct. Absolutely right. So that's because of the nasociliary nerve. Fine. So you look for all these eruptions in the eye, okay? Then you have to look for lid masses. Now this is a very important part, okay? Um, the masses, I mean the mass that presents on the lid, it can be anything from a benign lesion to a malignant lesion, right? And just by inspecting, you will not be able to tell because a lot of malignancies, they will, when you look at them, they might look to you as a very benign thing. That sometimes, for that matter, in the picture that's in the center, sometimes you might just mistaken it for a chalazion or something like that and not pay attention, and just post the patient for incision and curettage. So it's very, very important that, in a patient who is probably elderly or, you go for a biopsy, or for that matter, even if you do, uh, biopsy is going to be very, very helpful because, in this patient, this is our own patient. The picture that I'm showing, all these are actually our own patients. This one, the first one, it turned out to be a benign lesion. It was a nevus. The second one, first of all, initially we thought, I don't know, maybe it could be a lesion. Let's see what happens. But we thought because, and also one more thing, when you see any lesion on the lid surface, you have to evert the eyelid and see the undersurface. Now, eversion of eyelid is a very important thing because sometimes what happens is what you see on the surface, and when you evert it, you'll be completely surprised. I'll show you. You have to remember the image that's in the center, okay? Because a lot of slides that I'll show you further from here will be related to this particular man. So, and okay, the third one is okay, clearly you can see that it's something very, very nasty and it's very, fungating lesion. There's ulceration and all of that. So it might just be a tumor, a malignant tumor for that matter. So, okay. So for lid masses, you have to see that you have to inspect them. You have to, I mean, just how we do it in surgery, you have to check for that number, whether they're single or multiple, the site of it, whether it's on the lid margin or on the lid, I mean, the lid surface, or what is the size, an approximate size by inspection, then the shape of it, okay, and if it's how whether it's a well-defined lesion or an ill-defined lesion, how is the overlying skin, whether it's ulcerated, whether it has any, skin changes are present on it, if there's involvement of the lid margin, okay, because that's also important. I'll tell you how it helps you a lot in deciding what kind of surgeries you want to do. Then whether the lashes are present or absent, because sometimes what happens when the lid margin gets involved, all those structures are destroyed, the follicles are destroyed, the lashes will fall off and they will not be present. Okay, so that will be actually an acquired madarosis in a way. Then there can be ulceration, there can be discharge, there can be bleeding, so you have to inspect for all of that. So then after that, when you palpate, you have to look for any rise in temperature or tenderness, because that will tell you if there's any inflammatory lesion. Then you also have to look for whether there's mobility, and either if the skin surface, I mean the skin is mobile on top, or if the mass is, mobile from and it's separated from the underlying muscles or stuff like that, right? Then you have to look for consistency, whether it's firm or soft or what, and then you have to report it accordingly. Now I'm telling you again that it is very, very important that you evert the eyelid to examine. So now you again think of that picture that I showed you first, that man in the center, and then we'll go to, yeah. So this again, the picture in the center that you see over here is of the same person. Okay, so on top it looked, like a benign condition, but when you everted the lid, you see that there is so much activity that is going on over here. You can see these pinpoint lesions over here. You can see the yellowish, like it does not look very, very healthy, and it does not look very much like a chalazion as we were previously expecting. Even for that matter, in this third, I mean, the third picture that you can see on your right, and when the patient would, there was just a small little fullness, and she was a very young patient, approximately, I think, around 28 years or so. And when she presented to us, it also looked like a chalazion, right? But when we everted, you see that this whole thing, the lid margin is everted. I mean, the lid margin is involved, and there is involvement of the palpebral conjunctiva as well, just next to the lid margin. Okay, So eversion is very, very important when you see any mass on the surface or even otherwise, because eversion of the lid can even tell you, what kind of conjunctivitis it is, or if, the patient has had a history of trachoma, because all these will, lead to points in favor of your diagnosis. You'll be able to rule out and rule in a lot of conditions. The first image that you see here is over here also the patient had just a localized swelling on the surface of the lid. But when we everted, we found this uh, grape-like mask that you can see on the eyelid, right? So this is actually a pyogenic granuloma, right? So, okay, yeah. So, why is all that examination important? Why should you know how many, how much, what all is it is involving, and what's the size of the lesion? Because we have to decide our plan of action accordingly. Well, like what are we going to plan for the patient? So, if once you've done the biopsy, it come out to be malignant. Now you know you have to remove it. It's a cancer. You can't just leave it like that, right? So, if there are small defects, right? If they're only up to 25% or 30%, in young people, you can directly, I mean, just resect it and directly close the lid, just suture the two ends together. Okay, and because older patients, they have slightly lax lids, and what can happen is even if the defects are up to 40%, the lids will be able to approximate, even if because they are lax. Now, in moderate size defects, what happens is you have to do multiple procedures. Like there are this TENSILS procedure, which is a semicircular rotational flap. The TENSILS you can see in the images that are given. So basically, you mark the lid as to how much is to be resected, and it goes in two semicircles. One semicircle would go on the lid, which will tell you, I mean, depending on whether the upper lid or the lower lid involved, and the other semicircle goes in the opposite direction from the lateral canthus, uh, further laterally, right? And there are various other procedures like Hughes procedure, Heath's procedure, Mustardi's flap, and Callahan's procedure. Then, if there are very large defects which we've created after excision, then you have to go for multiple procedures like these. You have to choose which suits the patient the best. Okay, so the image that you're seeing here, the first one is the post-op image of a Cutler beard stage 1 procedure. Okay, and the second one is the stage 2. So after, what happens is in Cutler beard, you will create, for example, over here you can see that the two lids are actually now approximated, right? The up lid has gone under a bridge of the lower lid, and it's been sutured to the lower lid, right? And in the second one, we've tried to create a plane between the two after the surgery. So then the lids get separated, and it's given a very good cosmesis. Okay, so you have to basically, what you have to remember is that there are, depending on the size of the defect that we create after excision, that is how you decide what kind of surgery will you do for the patient. Okay, the size of the lesion, the location of the lesion, okay, and the size of the defect that is created after excision will help you decide all these factors, like what kind of surgery you're supposed to do further. Okay, and what you have to remember while doing all these surgeries that you have to replace like for like, right? Uh, Okay. So I'll tell you what anterior lamella and posterior lamella are, but briefly for now, I'll just tell you that the lid is actually functionally divided into two layers, right? There's an anterior lamella, which consists of the skin and the muscle. And then there's a posterior lamella, which comprises of the tarsus and the conjunctiva. This is very important. You should remember it that it's into two portions, the anterior lamella and the posterior lamella. So now sometimes what happens is when there is, sometimes you will just excise the skin and tarsus, right? So, sorry, the skin and the muscle, and you don't touch the tarsus and conjunctiva, only the anterior lamella you've touched. So when you have to replace that portion after excision, you make sure that you do it by similar structures, right? So then you replace it by the skin and muscle only, the grafts that you take for that matter, or the flaps that you take, right? And in the posterior lamella, if you've excised some portions of the posterior lamella, you make sure that it is replaced by similar structures. Now that's very important to principle for any sort of grafting or flapping that we do after excision. Now, what is the difference between a graft and a flap? Can anyone tell me? How do you differentiate between graft and flap? Correct. So a graft a flap is the one that has its own vascular supply, so it is usually taken from structures around and repositioned to fill the defect that we have created. Whereas a graft, it can be taken from anywhere, right? And it does not need to have its own, I mean, it does not carry its own blood supply. It uses the host site ka blood supply, right? So flaps are better in a way because they will not get, necrotized so easily because they actually retain their own blood supply. And when we're excising the tarsus is an important structure. I told you it lies in the posterior lamella. It is the fibrous part of the skin, so it is the fibrous part of the lid, and it's very important for the structural integrity, or it's the skeleton of the eyelid. So because it gives so much strength to it, you do not want to excise it so much that eventually the eyelid will become very floppy, right? So what you want to do is when you are excising the tarsus, you make sure that the at least 4 mm of the tarsus remains so that the structural integrity is maintained, right? Okay. Yeah. So this is what I was talking about. So once you're done inspecting from the surface, you also have to look at the eyelid margin. Now, this is a very important part of eyelid examination. You will get to know about a lot of pathologies just from here, right? And a lot of eyelid pathologies or, a lot of senile changes of the lid and everything. It goes around when you look, I mean, you'll get to know about it when you look at the eyelid margin. So now this is the eyelid margin, okay? Okay, you first look at the anterior portion. Okay, this is, just use the pointer 1 second. Yeah. So this is the anterior lid margin. Okay, the one that's present the anterior most, just that small little line that is going, that's the anterior lid margin. Then what you have is the anterior lamella. Okay, which is can you see this gray line that's going from here? So that splits your eyelid basically into its two things. That's the anterior lamella and the posterior lamella. So there's a gray line that splits the eyelid into anterior lamella and posterior lamella, right? So the anterior lamella, it comprises of the lashes majorly, okay? And it comprises of skin and muscle. So you can see that orbicularis muscle over here, orbicularis oculi, and the skin that comprises your anterior lamella, okay? And what you can see at the lid margin and at the anterior lamella are these lashes. Okay, you have to look at the lashes very carefully. I'll tell you what all to examine in the further slides. Then there's this gray line that you have to see, right? And this has a lot of significance because sometimes you have to do eyelid splitting, right? And that is usually done at the gray line. You split the eyelids at the gray line. For so many surgeries of, whether entropion, ectropion, and things like that, you have to split it at the gray line. Then there is a posterior lamella, which comprises of the tarsal glands and the palpebral conjunctiva. Now, at the lid margin, what you'll see at the posterior lamella are these openings of the meibomian gland, okay? Followed by that is the posterior lid margin, which has to lie in approximation with the globe. Okay, that's important, right? So you will look for all these things. Okay. Then as I already said, lid margin, it's examined on all these things. You have to examine the anterior lid margin. You have to examine the lamella, which comprises of the lashes on the lid margin. Then the posterior lamella will comprise of meibomian gland openings in the lid margin. Then you should look for the posterior lid margin, the thickness of the lid margin, and the orientation of the lid margin. I'll tell you how to do all of that. So anterior lid margin is usually rounded, okay? And you on the anterior lid margin, you're supposed to look for if there's any crusting or scaling because that will suggest that the patient has a squamous blepharitis, okay? Or if there's ulceration, that suggests an ulcerative blepharitis, right? Or anything, inflammation, any signs of inflammation or increased vasculature, you should look for in the anterior lid margin in the lamella. Then coming to the anterior lamella, I told you that what you'll see are basically the lashes. So in a normal eye, you have more number of upper eyelashes than the lower eyelashes. So in the upper lid, there are about 100 or 150 eyelashes, and in the lower lid, there are about 50. Okay, and what you're supposed to look for is the number of lashes. As I said, you will not be able to count each of them, but you can relatively see that in the upper eyelid there are more. And the rows of eyelashes, usually there'll be 2 to 3 rows, okay, but sometimes there are extra rows of eyelashes, okay, so that is also a condition. I'll talk about it further. Other than the rows of eyelashes, then you're supposed to look at the direction, All right. So the upper eyelids, sorry, in the upper eyelid, the lashes go forward, up, and back. Okay, and in the lower the lower eyelashes, they go forward, down, and back. Now that's important because any misdirection in the lashes, it will cause, if at all it rubs onto the cornea, it's going to cause a lot of discomfort to the patient. Okay, so we have to look for all those things. Then you also have to look for the follicle. Okay, the follicle is the place from where the lashes are arising in case there's any inflammation, or anything of that sort. That also you're supposed to look for when you're examining the lashes. Then here are a few conditions. Now, what is madarosis? It's basically absence of eyelashes, right? So you can see here in the lower lid, the lid is thickened also. It looks slightly inflamed, and there's absolute absence of lashes on the lower lid. Then coming to the second image on top, you can see graying of the eyelashes, right? That's called oleosis. Then the third one over here is, you can see this schematic diagram. So you see over here that there are normal lashes. Then in the second image, which is labeled trichiasis, you can see that there is misdirection and the lashes are rubbing onto the cornea. Then dystrichiasis, what is that? When there are extra eyelashes which are growing from the meibomian gland, okay, that is dystrichiasis. Now they can be misdirectional, they may rub on the cornea and they lead to ocular irritation and watering and things like that, okay. Then in the posterior lamella, I told you that you'll be able to see fine openings, which are the meibomian gland openings. Okay, and can anyone tell me where are meibomian glands located in the eye? Like which structure of the eye or which layer of the eye houses the meibomian glands? Yes, correct. They're in the tarsal plate. So now you can see why are they, do you understand now why are they in the posterior lamella? Because they arise from the tarsal plate, which is a part of the posterior lamella, right? So if there's any clogging of the ducts of meibomian gland or openings of the meibomian gland, that is, and that you can see that cheesy white material coming out of the duct openings. Okay, so this is called meibomianitis, right? Or meibomian gland dysfunction. Okay, this is also very, very important because it can lead to a lot of ocular surface inflammation, right? And it's actually, you are supposed to. Okay, what do you do if a patient with meibomianitis comes to you? Can anyone tell me that? Okay. So when such patients come to you, you're actually supposed to advise them hot compresses. Okay. Also, along with that, there is a particular way of doing lid massage. Okay, to express all these meibomian secretions. Right. So you anesthetize the eye just by putting pyrocaine into the eye, 1 drop of pyrocaine. Then you have to actually express. Uh, so you can put a swab stick on the undersurface of the lid and a swab stick on top of the lid, and then squeeze so that you approximate both the swab sticks together. What will happen is all the glands will get squeezed out and the secretions will come out. You can do that, and if it does not heal, you can also try giving them doxycycline. That also works with the woman gland dysfunction. Then looking at the posterior lid margin, they are supposed to be very sharp. The posterior lid margin is supposed to be sharp because it is the main one that is involved when to distribute the tear film properly when there's blinking action. And this has to be approximated to the globe. Okay. Now you have to look for the lid margin thickness. Okay. If it is very, very thick, it's called tylosis. And you have to look for the orientation of lid margin. Now, if the posterior lid margin usually has to be, as I already said, well approximated to the globe. In case there is inward rolling of the lid margin, that is called entropion. Why does this happen? Is because the anterior lamella, it will ride over the posterior lamella. Okay, so it will go inwards. Okay, and what is outward rolling? That is ectropion. Why does this happen? That's because when the posterior lamella, it overrides the anterior lamella and comes forward. That is called outward rolling. Usually what is there that the anterior lamella and posterior lamella are at the same level. In case there is any overriding of any of the lamella, that will lead to entropion when the anterior lamella is riding over the posterior, and ectropion when the posterior lamella is riding over the anterior. Okay. Also, some patients may come to you with all these things when they've suffered from trauma, and then you can see that the lid margin is lacerated and lid is also involved, right? The surface of the lid is also involved. Okay, then a few congenital anomalies for the end. You can see here in the first image. I'll use a pointer just a second. Yeah. Okay, so in the first image, you can see that this child over here, both the lids are, they're attached by a fine string, right? So that is, yeah, this is ankyloblepharon. Okay, the first condition here is ankyloblepharon. Then the second one, you can see that there is a defect in the lid per se, like, there's a congenital defect in the lid. And this is called a coloboma. Okay, so this is a congenital lid coloboma, and that happens because of failure of there's an embryonic fissure which is supposed to close at a particular stage of the gestation, right? When that does not happen, that leads to defects like these. Okay, there are various other colobomas also that you can see in the eye, but because we're talking about only lid here, I'm showing you this. It can be associated with multiple other colobomas. There are colobomas in the eyes, I'm sorry, the iris. There can be a fundal coloboma and things like that, right? Then over here in the third image that you see is, yeah, so this is epiblephron. Can anyone tell me what is an epiblephron? Yeah. So it is an extra fold of skin. So okay, when this comes from here, hello. Okay. So yeah, so this is epiblephron when there is an extra fold of skin. Then in this one, the last image that you can see, that's actually an image of blepharophimosis syndrome, right? So what you can see over here is that the patient has ptosis also. There is an increased intracanthal distance. So between the medial canthus, you are going to see a lot of space, like it's more than the normal. Okay, and then you see epicanthus inversus. This is epicanthus, okay, where there's an extra fold of skin which is coming from the upper eyelid. And when the lower eyelid is giving an extra fold of skin, that is epicanthus inversus. Okay, so all this is a part of your blepharophimosis syndrome. Okay, there are more features also to this. There's a lateral ptosis, I mean lateral ectropion and things like that. So I think with that, I'm coming to the end of the class. If you have any questions, you can post. Yeah, so to summarize, I'll tell you that you have to start looking at the eyelid externally. I mean, you have anyway, in general, when you do ocular examination, it starts externally, right? So ideally, we go for the orbital examination first, but I'll be dealing with it in probably the next class. So in the lid, you're supposed to look at the position of the lid, the skin surface of the lid. Okay, and if it's for example, if you find any lid position abnormality, then you're supposed to go into that direction. Then you have to examine completely in the lines of ptosis examination, right? Then other than the skin, you should look for the lid margin, right? So you in the skin, you look for all the discoloration, if there's fullness, if there are any masses, what are the extent of these masses and things like that. And then you look for the lid margin. If your lashes are normal, if this margin per se is healthy, whether there's any inflammation or any ulceration or anything of that sort. Then you look for the meibomian gland openings. Then you have to evert the eyelids. That's very, very important. You have to evert it and look for if there's, like follicular conjunctivitis or papillary conjunctivitis, or if there is a mass, then what if it's extending onto the, palpebral conjunctiva and things like that. That's very important. Yeah, epiblepharon and epicanthus is the same. Epicanthus inversus is where the lower, the extra fold of skin is coming from the lower eyelid. Anything else do you have that you have to ask? Okay. Okay, LPS function, what you have to do is first of all, you just make the patient stand next to a wall, okay? I mean, with the back, uh, supported and everything against the wall, right? And what you do is you ask the patient to look down. I'll go back to that image, one second. Yeah. So, with the head against the wall and everything, once it's all stable, then you ask the patient to look down. And then you put a scale next to the upper eyelid. Okay, जो lid margin of the upper eyelid, you put a scale next to it and align it with the upper lid margin. So over here in this image particularly, we've aligned it next to 1 centimeters. So that is the zero of our reading. Okay. Then what you do is when the patient is looking down, you block the action of frontalis because otherwise the frontalis will be elevating the lid and you will falsely interpret as the LPS action also. Okay, so you block the action of frontalis by putting thumbs over just above the eyebrow. Okay, you'll put both your thumbs above the eye. I mean, your left thumb over the right eyebrow of the patient. For example, if you're examining this eye, your left thumb will come over the right eyebrow of the patient. So you block the action of frontalis over there, right? Then once the action is blocked, then now from the complete down gaze, you're supposed to ask the patient to look as far up as possible, like as up they can, uh, they'll look up. And again, then what you do is, then you check that where is that lid margin, upper lid margin lying, I mean, matching with the scale. So over here that you can see it was first on 1, that we aligned that on 1. Now it has come to 1.5 or 15 mm, right? But since we started from 1, we're going to eliminate this 0 to 1 wala thing. So it's actually you're measuring the excursion of the lid, and that is only 5 mm. So it's gone from 1 mm and the lower, I mean, in the down gaze to it's gone up 5 mm up in the up gaze, in the extreme up gaze, right? So that is how you measure the LPS action. Okay, yeah. And also, somebody is asking Bell's phenomenon. What you do is I don't have an image of it. Okay, I'll show you an image in the next class, but for now, I'll just tell you how to do it. What you do is you hold both the upper eyelids, okay, and you elevate them. You elevate them like actively by yourself, okay, and then you ask the patient to forcefully close the eyelid against the resistance that you're giving by pulling up both the eyelids, right? So the patient will be trying to forcefully close the eyelid. Now in that you'll observe where are the eyeballs going, okay? Usually they go up, okay? They can also sometimes go out, sometimes go in, and according to whether they're going out or in, you call them inverse or reverse, and sometimes they'll go in down. Okay, so there are various things. Normal is when it goes up and out, and then it can go up and in also, or it can go down and in also. Okay, so accordingly they're called reverse or inverse. Anything else? Okay, yeah, the significance of it is that if there is a poor Bell's phenomenon, for example, if the eyelid is not going up, okay, so we usually defer the ptosis surgery because if we do ptosis, we are elevating the eyelid, okay, and now if the patient, for example, हमने उसको elevate कर दिया and now the patient is going to sleep, but the eyeball does not move up, okay, and it stays right there. So what happens is when the patient is sleeping, there's no closure, and that will lead to exposure of the cornea and everything, and that gives rise to exposure keratopathy, and that is not something we would want for our patient because it has grave consequences also. Like initially, it will be very just irritation and things like that, but it's not very comfortable for the patient. Is there any other question? I don't know when will the college open. Anyway, I think if there are no questions, we can close the session. Okay. Difference between epicanthus and telecanthus. Now, see, I told you that epicanthus, one second. I'll show you the image so you can better relate to it. Yeah. So you see the image over here. Yeah. You see this? Okay. There's an extra fold of skin that is coming from the superior lid to the canthus, right? Over here in this direction. So this is your epicanthus because it's coming from the top. Okay. And the same thing you can see in the image over here also. Now, what we're talking about telecanthus is when this distance between the two canthi, okay, that is increased from here to here. That is called telecanthus. Over here in this image again, what you can see is that there's an extra fold of skin that's going from bottom to top, okay, from the lower lid to the upper lid or to the canthus over here. That is called epicanthus inversus, okay, because this is the reverse of what we saw in epicanthus. Is that clear? All right. So I think if there are no further questions, I'll close the session. Thank you.